I'm Pam Taub. I'm a cardiologist and professor of medicine at UC San Diego, and I'm joined today by my colleague, Seth Martin.
Pam, it's fantastic to join you. I'm a cardiologist and a professor of medicine at Johns Hopkins.
Well, we're going to talk today about the best way to measure atherogenic lipids. This is something that we struggle with clinically because there's so many different measures. There's LDL particle number, there's ApoB, there's LDL-C calculated by numerous different equations. And I think the average clinician struggles with what is the best way for me to assess the number of atherogenic particles that can deposit in the arterial wall and lead to future cardiovascular events. So this is an area where there's a lot of different opinions. Let's start by getting your opinion, Seth.
That's right, Pam. There's certainly been some debates in this field that have been raging on for decades and continue to rage on. But I think the answer does partly depend on, I think, what you're comfortable and knowledgeable comfortable with and knowledgeable about, what the guidelines say, and really trying to bring the most information to inform decisions with your patients. And so these different lipid measures are not necessarily mutually exclusive, but can provide complementary information. Of course, LDL cholesterol has been at the center of preventive cardiology and center of the way that we basically manage lipids to prevent atherosclerotic cardiovascular disease. But the classic method by the Friedewald equation, which was developed in the 1970s, does tend to, in the modern era, pose some problems, particularly underestimation, which could lead to undertreatment of high-risk patients. So there have been in that setting, new approaches to assess LDL, as well as that can mean that there's a particular advantage as well to other lipid measures.
So I completely agree. And the Friedewald equation is especially problematic in our patients with metabolic syndrome and diabetes that have elevated triglycerides. And the Friedewald equation underestimates their LDL. And so you end up underestimating risk and undertreating these patients. So for these patients, the first thing I do is I calculate a non-HDL, which is a very simple calculation. It's just total cholesterol minus the HDL. And typically the non-HDL should be about 30 points higher than the LDL. And our non-HDL targets are about 30 points higher than the LDL. So if you want an LDL of 70 for a patient, your non-HDL should be about 100. So I find that clinically very useful. I know that you have developed an equation for calculating LDL. So tell us what made you decide to invent this equation and how did you go about doing this?
Yeah, thanks, Pam. When we first published in JACC in 2013, from our very large database of lipids showing the underestimation by the Friedewald equation. By the way, the Friedewald equation has made a great contribution to science. It's one of the top 100 cited papers of all time. It's really impressive what they were able to produce back in the 1970s. But the challenge is that they recognize is that the component of the equation that's estimated it's basically triglycerides divided by 5 in milligrams per deciliter. So as someone, like you say, with metabolic syndrome who has higher triglycerides, there is a tendency for that does amplify the inaccuracy of the equation. And it was traditionally thought that if your triglycerides were below 400, then the equation would be accurate. However, we now know that even at much more modest elevations of triglycerides of 150, 200, 300s, there can be significant underestimation with the Friedewald equation. And so when we first published our paper in JACC, we thought, you know what, the solution is non-HDL, just like you say. So we didn't think there was really a need immediately for anything else. But then as time went by, I realized, you go to the meetings, the primary outcome of the trials is always LDL cholesterol. When I talk to our cardiology fellows or internal medicine residents, they've never heard of non-HDL. They all know what LDL is. And we try to try to teach, but it's clear that clinicians are very comfortable with LDL. The trials have used LDL, guidelines are based on LDL. And that's really what our drugs are directly treating. Whereas when you add in the rest that goes into non-HDL, although it does carry risk, it's not as directly related to the drugs that we're using. And so for that reason, I did work on a new equation back then, about a decade ago. And really all that we did was we had a large database, and instead of dividing by 5, like a one-size-fits-all approach, it's just an individualized approach where that division factor is tailored to the lipid profile based on your triglyceride and non-HDL levels. So it does take into account non-HDL, but the predominant factor that explains someone's ratio of triglycerides to VLDL, which is the estimated component, the predominant factor is triglycerides that kind of determines that. So we put forward this equation, and it's really been amazing to see all the literature since then that's provided validation. We do have a paper coming out in Global Heart that there's actually been now more than 20 LDL equations that have been proposed in the literature. And what our paper will show is that actually most of them perform worse than the Friedewald equation. So the Friedewald equation, in a sense, has stood the test of time. However, it is time to, I think, for laboratories to change their practices, to update. And I recommend using the method we've developed, because it really provides, I just looked up the last 5 papers that have come out on this topic as well, and all of them recommend using the method we've developed compared to the Sampson NIH equation and other equations. Unfortunately, the Sampson equation does still underestimate LDL cholesterol levels, not quite as much as the Friedewald equation, but it still does, in people with lower LDL concentrations with elevated triglycerides, underestimate LDL, probably partly because of their smaller sample size, as well as the odd distribution of lipid levels that were in that the population used to derive that equation. So the concern is that then that would lead to us using less proven LDL lowering therapies, statin and non-statin therapies, including ezetimibe, PCSK9 inhibitors, bempedoic acid, and so forth. And so this could mean, keeping people free of cardiovascular events. It could mean saving lives, depending on which decision, what equation we're using to base decisions. But of course, there's an opportunity to go beyond LDL equations as well, to kind of round out the knowledge that we use to guide lipid management.
So I'll tell you one thing that I get very frustrated about as someone who does a lot of clinical trials is the use of LDL as cholesterol by the Friedewald as one of the primary outcomes for many of these studies. We really need to move beyond that, and we really need to start using non-HDL or a better LDL equation like yours. What can we do to really go towards more standardization? Because as you said, there's so many equations. Can the professional societies take a stance? Like, what can we do?
I think we should continue to kind of discuss and debate this and bring forward guidelines. Guideline recommendations can be quite helpful, I think. So the ACC, HA, EAS, Polish Lipid Society, Brazil Lipid Society, the National Lipid Association in the US have all recommended using our equation. I think that is helpful, and that does provide a stronger basis to then, as clinical trialists are planning their trials. So we've started to see it being adopted into some trials, which is great. And we've also been able to retrospectively assess it. For example, in the Fourier trial, I was able to collaborate with the TIMI group, and they had done ultracentrifugation down at levels where the Friedewald equation was below 40. So we were able to go back and show that if you had, instead of the Friedewald equation, used our method, it actually lined up really well with the ultracentrifugation results. So that provides additional evidence of its performance at such low levels in a intensively treated population, but also further kind of justification for clinical trialists to use it in the future for future trials, which can make it align better with clinical practice, because we know ultracentrifugation can't be scaled in practice, but also just make the trial more cost efficient.
So I think you've heard it from the inventor of the Hopkins-Martin equation that this is the equation that we should be using. in our clinical practice and in clinical trials. In addition, there's a lot of other options. So we talked about non-HDL, but you can also measure ApoB, you can measure LDL particle number, and those two assessments also give you a good sense of atherogenic particles. The only issue is there is an additional cost. But I love LDL particle number, and I use that for a lot of my patients, just because we know that atherosclerosis is a gradient-driven process. Right. And the more LDL particles that you have, the more likely they are to deposit in the arterial wall. And it's also a concept that's easy to convey to patients about these are the number of bad particles you have. We treat you with a statin or other additional agents, and this is the decrease. So I like that in terms of just being able to explain it to the patient. Do you use ApoB or particle number in your practice?
I do use ApoB in my clinical practice. It's something that I've been a fan of for many years and followed the work of Alan Snyderman and many on this topic. It is recommended by guidelines to use apolipoprotein B. In our National Lipid Association statement, we did raise you brought up the point about standardization. I think in general, in the world of lipid measurements, we should always be pushing to the best possible standardization and harmonization, because the better data is going to provide better clinical care, especially as patients go across hospitals and health systems. So I think there's still room for improvement, but already it's a very good measure. And back to the point about things not being mutually exclusive, there's complementary information. Even if ApoB hasn't been the primary measure used in as many trials and so forth, it's clear that it's a really great, a particularly strong measure of cardiovascular risk. And it's such a simple concept that there's one ApoB, for every bad particle or every atherogenic lipid particle. So it's also something that's, can translate in clinic to explain that. So yes, I do use it in my practice as well. But I'll say once we update the LDL equation, there's less change in decision making that it would lead to, but it still often does help round out the picture, and so find it useful in that regard.
So another confounding factor that we should take into account when we're assessing response to statins is if patients have an elevated lipoprotein A level. Recently, there was a paper published in JACC by my colleagues at UC San Diego, Dr. Calvin Yang and Sam Semikis, looking at how lipoprotein A impacts LDL levels. And so they came up with a correction in which you account for LPA. Yeah. And we see this clinically. So for instance, when I start patients on, for instance, 40 milligrams of rosuvastatin, I expect at least a 50% decrease in their LDL. And sometimes you don't get that. And then there's this concept of statin resistance. Why is this patient that's on this high intensity statin not getting the expected benefit? And this concept of lipoprotein A contributing to statin resistance is very intriguing. And we should start looking at that more in clinical practice. In fact, the European Atherosclerosis Society and European Society of Cardiology say we should be measuring a lipoprotein A once in everybody's lifetime. And this makes complete sense, especially when we're looking at LDL. We also need to understand what the lipoprotein A level is. So what do you think about this new concept of statin resistance due to elevated lipoprotein A?
Pam, great question. And I totally agree with you. I do measure lipoprotein A in my clinical practice for that very reason. You and the UCSD group have done great work teaching the world around lipoprotein A, and it's exciting to have directed therapy on the horizon. And so that we're going to learn a whole lot more about LPA in the years to come. But in current times, because LPA is part of the standard definition of LDL cholesterol, if that part is not being changed by statin therapy, it's going to blunt the response that we see and lead to a less than anticipated result. And so if we use the corrected LDL, that can allow us to see that the other parts of standard LDL cholesterol were modified as expected by therapy. I think it's important not to that this is a complementary measure in that clinical setting, but not to then use this corrected measure when deciding on the threshold, for example, for adding non-statin therapy, because there we want to stick with the standard definition of LDL that was used in the trials and used in the guidelines.
Yeah. Well, I think there's a lot of things that we have yet to learn, but I think some key takeaways are that we really need to be going beyond just LDL-C in our assessment of atherogenic lipoproteins. We need to be looking at non-HDL and ideally using equations like yours to better assess LDL. But in addition, we need to be thinking about some of these biomarkers of residual risk, such as lipoprotein A. We also need to be thinking about triglycerides and how triglycerides, especially when they're elevated, can confound our LDL measurements, because it is such an important measurement. We do so much therapy around LDL that we want to get the measurement correct.
Absolutely. That's absolutely right. We want to get the measurement correct so we can make the best decisions with our patients and prevent cardiovascular events, prevent death, because we're fortunate to have such effective therapies. And really, in order to best implement them, we need to be basing decisions on the best data. Admittedly, it is getting a little complicated because we have multiple measures, we have multiple drugs that work. But ultimately, I think we need to embrace these complementary measures and embrace the different lipid therapies we have, because they can really help our patients.
Well, thank you, Seth, for your incredible contribution to the field. And we've learned so much from discussing all the different measures of atherogenic lipids today.
Thank you, Pam. I really respected your major contributions to the field and leadership in preventive cardiology, and it's always a great pleasure to talk lipids with you. So thank you so much.